Good afternoon, everyone, and welcome to the 2021 Caregivers Summit. I am Mary Lucas, the Director of Business Development at Transitions Life Care, the leading provider of hospice, palliative care, and home health services in Central North Carolina. We're pleased to host today's webinar on understanding Medicaid benefits for nursing home care and what Medicaid managed care means to you, the third of 4 webinars aimed in our Business of Caregiving series this month. Because we want you to get the most out of this experience, we've invited our speakers to present first, and we will ask questions along the way. At any time, we invite you to post your questions in the Zoom Q&A box, and we'll make every effort to get those questions answered at the end of each presentation. Darcy Dye-Bowers, the Senior Communications and Public Relations Manager here at Transitions Life Care, will be working through the Q&A as quickly as possible. Please make sure to put your questions in the Q&A box and not the chat. Additionally, we will be recording these webinars and posting them on the website by the end of each day. First, we want to take a minute to thank our strategic partners as well as our sponsors who have helped promote the Caregivers Summit. Our strategic partners are the Alzheimer's Association of Eastern North Carolina and the Dementia Alliance of North Carolina, who both provide very important resources for those trying to navigate the complexities of dementia and Alzheimer's. We're also grateful to our sponsors for their financial contributions that make the Caregivers Summit possible. An extra special thank you to our gold sponsors, the Potter Financial Group, North Carolina Senior Medicare Patrol, and UnitedHealthcare. Because of them, there was no charge for you to participate today. Today, we'll be talking about the Medicaid benefits and what Medicaid managed care means to you. And we're honored to have 3 experts to help us understand more about this topic. They are Deputy Secretary for North Carolina Medicaid, Dave Richard, Dr. Michelle Bucknor, Chief Medical Officer with UnitedHealthcare, and Jonathan Williams, attorney with Clarity Legal Group. That's a mouthful. First up is Dave Richard, the Deputy Secretary of North Carolina Medicaid, where he leads North Carolina's $14 billion Medicaid and North Carolina Health Choice programs for the State Department of Health and Human Services. Richard's vision for Medicaid is to ensure a sustainable, person-centered, and innovative Medicaid program for more than 2 million North Carolinians who use Medicaid. As the programs undergo transformation to even better fit the needs of the state and its residents, he is committed to the fundamental goal of improving the health and well-being of all residents. Richard believes the right way to achieve success is to work closely with stakeholders in all aspects of Medicaid. Prior to leading Medicaid, Richard was the Deputy Secretary for DHHS Behavioral Health and Developmental Disability Services in the State-Operated Healthcare Facility Division. He joined DHHS in May 2013 as the Director of Division of Mental Health, Intellectual and Developmental Disabilities and Substance Abuse Services. Richard joined DHHS after leading the ARC of North Carolina, an advocacy and service organization for people with intellectual and developmental disabilities, as its executive director for 24 years. Thank you, Dave, for joining us today.
Thanks a lot for inviting me, and really look forward to this conversation. And we can just go to the next slide. We'll start there. One is that I appreciate folks joining, and if you have heard about Medicaid transformation, please forgive me. I'm going to run through these slides pretty quickly, but I want to make sure people understand what we're trying to do. First, you should know is that this transformation that we're undertaking is actually the biggest change in North Carolina Medicaid in its history. We are a 50-year-old program in North Carolina. We are moving from a system in which we as the state pay directly claims for our services to providers, your doctors, your hospitals, and other providers, nursing homes, and other long-term care providers, to one in which over time we will use a managed care organization to do that work, which we'll oversee in that effort. The transformation takes place over several years, and I'll talk a little bit about what that looks like initially. But what I want to first start out by saying is that when we are moving to managed care, which is a legislatively mandated effort, there are lots of reasons why people think about that. And I want to assure you that this isn't the managed care program that you may have heard about 20, 25 years ago. It is a totally different way of thinking about delivering services to people, especially our Medicaid beneficiaries. And I put up this vision statement because, I don't know about you, but often you'll see vision statements and they wind up sitting on a wall and people don't think about them. But this really does capture what we're trying to achieve as we transition to managed care in North Carolina. And I'm going to read it. Typically don't do that, but I think it's important to hear the words, right? It is to improve the health of North Carolinians through an innovative, whole person centered, and well coordinated system of care that addresses both the medical and non-medical drivers of health. Now, it's a mouthful, a long sentence, but I want to break that down a little bit. We can look at the next slide and talk about what those things really are. First, focusing on whole person care. What we have learned over the last decades in healthcare, across healthcare, is that when you go to your doctor, and we love doctors, and you can hear from Dr. Bucknor in just a minute, they provide great support in healthcare, but it's only one part of making sure that we are healthy. And I think when you think about this, it becomes pretty simple, right? Is that when you spend, I'll talk about me. I go, quarterly to my primary care physician. He does a great job. I love the work he does. But if after I leave his office, I don't take his advice and think about the things I should be doing to be more healthy, I just go back in a quarter and he's telling me the same things and nothing changes. For example, I have a chronic heart condition. If I don't pay attention to my diet, I don't get good exercise, I'm not, making sure that I reduce stress, then everything he does in his office, frankly, is not going to have the impact that it needs to have. When we think about, for me, I'm fortunate. I have access to a health club. I have access to really the kind of food that I need. I can drive to get my meds. I can make sure that I have the kind of life that reduces stress outside of work. But for so many people on our Medicaid program, and frankly, people across the state and other programs, that's not the case. So we really believe that driving what we call those unmet social needs, or you might have heard social determinants of health, is really critical, just as thinking about the behavioral health of individuals. So when I had the heart troubles beginning, one of the first things that people told me is that you really need to think about what's that doing to your mental health services. So why don't you spend some time with a counselor to do that? Again, I was able to do it, but that's what we want for all of our Medicaid beneficiaries and frankly, people across the state. We also know, I mentioned my primary care physician, we know that care management for individuals, actually the ability to think about how you manage this program, is best done at the local level and with that primary care provider. So our Medicaid managed care program isn't going to have their care management provided for beneficiaries by telephonic efforts. It's going to be at that local level when you're working with your physician, and that's how we want to deliver those Medicaid beneficiaries that go forward. We'll do the same thing for our behavioral health. And then we think about how we purchase services for folks. Often, in the past, what we've done is that we've purchased services based upon showing up for an event. What we really want to do is to think about longer term strategies about how do we pay for quality outcomes? How do we think about reducing health disparities by thinking the outcomes that the providers will make there? So think about someone in a long-term care program. Well, it's not just enough, right, that somebody's in that long-term care program. We want the right quality outcomes. We want to make sure that their health is good. We want to make sure that they're having the social activities that are needed. And we want to be able to measure those outcomes. And that's how we want to ultimately pay for these services. So we can flip to the next slide. When we say that's what we're trying to do in our transformation, I want you to think about managed care in a positive light. And you're going to hear Dr. Bucknor talk about the things that they're 2.5 Medicaid beneficiaries, that what we're doing is it's transitioning because we will provide better health for all of our beneficiaries as we go forward. What we're changing is that from, again, us at Medicaid paying for all those services, we're going to use 5 health plans: WellCare, United Health Community Plan, Healthy Blue, which is part of the Blue Cross, AmeriHealth Caritas, a new player, and Carolina Complete Health, which is a combination of a partnership between the Medical Society and one of our national plans. In addition to that, I'll mention that we're doing a totally new thing with our Eastern Band of the Cherokee Tribal, which they will manage the healthcare for the 4,000 tribal members in the western part of North Carolina. We will launch this on July 1st, but I want to tell you as we look at the next slides that we have actually begun the process already. So let me mention this real quick, is that Medicaid Direct is that there will be some people that don't go into managed care. There'll be some of our limited benefit folks, and then we'll also not have dual eligibles transition at this time. In behavioral health services for people with the most severe mental health needs and those with intellectual and developmental disabilities, won't launch those programs into 2022. So those individuals will all stay in the current process they are, which we call Medicaid Direct for those individuals. You can flip the slide now. Here's what I want to assure people, though, is that any kind of transition like this is hard. It's difficult. We are excited about our health plan partners. We think as the state, we've done the kind of work that we need to do to make the smoothest transition as possible. But anytime you do something as big, things will go wrong. So I want to assure people that our day one priority, and frankly, our day 90 priority, is that if you are an individual on Medicaid or you know someone on Medicaid, that they will get the care they need. Even if they show up to a doctor's office with the wrong card or a doctor that's not in their health plan, they'll still get the care initially that they need and won't have to worry about that. And most importantly, is make sure that our providers are stable, that they will get paid. So we want to make sure that everyone in this transition continues to get the quality healthcare that they need. Number one priority. I'm going to flip the slide. This is really the timeline that we're under. And so if you look right now, we're in open enrollment period. And what that means is for those 1.6 million beneficiaries, they get to choose a health plan. Here's the important part. Those health plans all provide the same level of Medicaid benefit that currently exists in a Medicaid program, but they will have different provider networks. So if you're looking for a plan to join, you want to make sure that your provider, your doctor, or whoever else that you see on a regular basis is in that health plan. And there's some value added services that they can provide. So some will provide some transportation availability that might not be available elsewhere. Some will provide additional food options. Some will provide support for young children. So whatever your needs are, you should look at those plans to make sure that you choose the one that's best with your provider, but also if they're provided added services, the service you'd like. That enrollment period ends on the 15th of May. But here's the important part to know. We know that when we launch managed care, as other states have done, a lot of folks won't enroll initially. So we'll auto-enroll people into the health plan. And the best way to describe that is we'll try to find the health plan that has their primary care provider in it to make sure that we assign them to the plan with that provider. Then we'll try to make sure that if they're families, we keep the families together in those plans. But once you're assigned to a plan, you will have any time, 90 days after we go live, to change plans if we've gotten you in the wrong plan. So I want to assure people that this is going to be as easy as possible as we make this big transition. Then we go live July 1st of 2021. The end of the choice period, we say, is 9/30. But frankly, if there's a reason why people need to choose a different plan, we'll honor that. And then every year at the time that they are determined eligible for Medicaid, they'll have an opportunity to change plans at that point in time. So we can change slides again. A couple of things I want to make sure people know is that as you go to sign up, you're going to sign up on our websites, and we'll show you all those in a minute, and that information will be available to folks. Is that when you look at that, it is run by what we call as an enrollment broker, someone who's totally independent from the state and from the health plans. So they'll be able to provide assistance for individuals as they have questions, either through the website or through a chat box or through phone. But it is an independent organization, so they're not going to steer people to a health plan that just because they want to steer you there. They'll help you get there because of what's best for that individual. Health plans all have member services, and you'll see that information as we go forward, so people can get information that way, and we'll show those there. And then we will have an ombudsman program to where if somebody's not happy with what's going on with their plan or need additional information they don't feel they're getting, they'll be able to do that and actually launch on April 15th, and it'll be gearing up as we go throughout this process. And again, the website's listed here. If we can now flip to the other slide. We have the health centers. So if you have a question about this, you can email us at this help center and we'll be able to get the information for you. But we also have and keep that information available so people can come there. You'll also be able to know when there are other webinars or other sources of information. And then we have this beneficiary portal that we encourage people to look for. You go in there, you can look at all the Medicaid resources that you need to be able to get information, both managed care and not managed care, as you look at that one. If we can flip to the next one. Here is what the enrollment broker website looks like. It is not only the website, but it's also a mobile app where you can go to and get on this website. It gives you information that you need on health plans, about which providers in health plans, and again, with those value-added services that the health plans will be providing to people. I do encourage folks to go there, but if the website's not your thing, go on the phone and make sure you talk to people. That will work for you also as a Medicaid beneficiary. And we can go to the next slide. I think the next couple are just some additional ways that you get there. I want to make sure you know that, again, you can do all of these things on the website with the enrollment broker, get your best information there. And again, the numbers that are right there for the North Carolina Medicaid plans.gov. And if we go to the next slide, here's again more information about how to get this. Also want to tell you something unique for Medicaid this year is that we're actually advertising about this change on radio, TV, and online, social media for people, and the health plans are doing the same. So you'll be able to get information that way. If you can't get it this way, you can probably see it on late night TV as you're watching stuff come through. Flip to the next one. Again, additional resources that we have for folks to be able to get information. Our goal is to make sure that we over communicate to people. You have everything you need as you go forward. Maybe the last one, let's see if that was the last one. Yeah, we're going to go over to UnitedHealthcare, but let me just say one more word to our transition out. The thing that we want to really encourage people to do is that if they can get to the website, call, choose a plan, make it best for what you can do. Secondly, though, be assured that if you don't do anything, you will wind up continuing to have your Medicaid benefits. Nothing changes at that side. We'll assign you to a health plan if you do not do enrollment. So encourage people, the people you know, to talk to them to please look at this, but also want folks to know that if you don't do anything, it doesn't mean you lose benefits. We'll just assign you to the plan and you keep the same benefits that you have today. And I'll stop right there so we can turn over to Dr. Bucknor.
Thank you so much, Dave. Does anyone have any questions, Darcy?
No, we don't have any questions, Dave. That was such a thorough overview, and I can predict that we may have some requests for these websites going forward. And as Mary told you earlier, we are recording this session, and when we upload it, you'll be able to see these slides. Thank you.
Thank you.
Wonderful. Thank you, Dave, and also thank you, Darcy. So next, I'd like to take a minute to introduce our next speaker, Dr. Bucknor. Dr. Michelle Bucknor is the North Carolina Chief Medical Officer of UnitedHealthcare Community and State. Formerly, she was the Chief Medical Officer of Community Care of North Carolina and the Medical Director of Community Care of Wake and Johnson counties. Dr. Bucknor has diverse clinical and administrative experience in academic, community health, hospital, and managed care environments focused on vulnerable populations. Prior to transitioning to an administrative role, Dr. Bucknor was a practice primary care pediatrician for over 20 years. She's committed to a holistic approach to improving the health of underserved community through community service and collaborative partnerships. Dr. Bucknor, thank you so much for joining us today.
Thank you for having me, and I'm really excited to present to this group and more excited to share our vision of managed care and what this transition will mean from the managed care perspective. So if you go to the next slide, as Dave shared the mission statement for the department, I think it's really important that you understand the mission of UnitedHealthcare also. So our mission is to helping people live healthier lives, really important, and helping making the health system work better for everyone. So many of you probably realize that as an insurance company, we're big and we have commercial products, we have Medicare, Medicare Advantage, dual special needs program, but I am the Chief Medical Officer for our Medicaid program. And I think in coordination with the state, we have an opportunity in this state like no other to really achieve both of our mission statements. So if you go to the next step, slide, for us, culture is really important. And I think, when I think about being a caregiver or being a person that engages with the healthcare system, I want to know that the people taking care of me really care. And I want to reinforce, we have culture workshops, we have culture ambassadors. And so we live and breathe these values of integrity and compassion and relationships innovation and performance. And so that is what we're bringing to the state. I will say, as an organization, we are extremely mission driven, but this North Carolina health plan team is mission driven like no other. Many of us, in fact, almost all of us have been in the state for years. Some of us were, born here and have lived here all of our lives. But for the most part, we've all been dedicated to making the health system work better. And so that's what we're here to do in coordination with the state with managed care. So the next slide. So when I speak about Medicaid managed care, although I'm speaking and I can only speak from a UnitedHealthcare perspective, I will say the state has created a framework. So what I'm speaking about today is really probably consistent for all of our managed care organizations based on the state framework. And to tell you the truth, it's the reason most of us are in the positions we're in. Many of us have had managed care experience, some of that within the state, some outside of the state. But I think when I speak about the chief medical officers and the clinical staff, we are here because of this framework and because of the opportunity that the state has given us to create health within our state. And so one of those things that excites me, and Dave mentioned it, is we will be addressing social needs. So it is the right thing to do, but we often haven't had the opportunity within Medicaid to address social needs like we do in North Carolina. And so if you are a Medicaid beneficiary or a member of any of the managed care organizations, we're required to screen 100% of our population for social needs. So that's transportation, interpersonal violence, housing instability, and food insecurity. And not only screen, but actually connect people to resources. We have a really cool, one-of-a-kind structure in our state where we have a platform that we can actually place referrals, but we take that extra step in making sure that we close the loop. And we're required to have a housing specialist. So if someone has housing needs, and I don't have to tell you the story of how homelessness can absolutely impact your health, but homelessness doesn't mean just on the street. It may mean that you just have unstable housing. And so we know that the majority of health outcomes isn't the healthcare we provide, it's everything else that happens in the community. And so on that point, we want to make sure that we're partnering with medical providers, not only to help us and the right healthcare services at the right time in the right place, but we also want to support them in. And so that's Dave also mentioned the Advanced Medical Home Program, and I'll talk more about that later, but that is where we are able to work with our primary care provider community, and they will have care management in their office or with an entity that supports them closely. And that, as a primary care, I'm a primary care pediatrician at heart, that, is the majority of my career, and have provided care management at the office level. And to have a state that is actually requiring that we work with the primary care community to provide this local care management is huge for us. Part of that is also improving access to care. So how do we work with folks to make sure that they are getting that right care in the right setting? And lastly, that coordination of services. The healthcare system, even if you don't have a chronic medical condition, is really hard to navigate, and wasn't designed to be that way, but that's how it's happened. And so we know it's important to work with people, whether they just have a healthy child or if they have complex medical conditions, to be able to navigate the system. And that's where we're providing that support to a large portion of the population with care management services in coordination with those advanced medical homes. Next slide, please. And so, Medicaid, the benefits will stay the same. So it's important to know that managed care doesn't mean any of these things go away. Inpatient hospital is still there, outpatient hospital is still there. The protections for young children up to 21 to make sure they get the services they need through EPSDT is still there. Nursing facility services are still there. Home health, the physicians, rural health clinics, FQHCs, or community health centers. So it's important to know that the foundation is still there. What we have the opportunity to do is bring extra, as Dave mentioned. So we do have value added services, and it may be cell phone, it may be GED support, it may be enhanced food benefits. So it's important, as Dave mentioned, to go online and look at the different plans and see what we're offering and see what those extra benefits, if there's something that can support you or your family members to help you choose the right plan for you. Next slide, please. So, whole person approach is unfortunately a new concept, I think, in medicine. It should have always been the concept, but we at United have certainly embraced that approach, and that's the expectation of the department. So, that's understanding how each individual circumstance in their life impacts their health and well being, and to understand where they are and acknowledge person-centered goals. So I, as a physician, shouldn't decide what your ultimate goals are. I can help you achieve those goals if your health has an impact on that. So, for example, diabetes. Yes, I want to manage your diabetes and get your labs at a correct level, but you, for your family member or for yourself, may say, well, I want to control my diabetes because I want to remain healthy so that I can support my family or play with my grandchildren or live long, right? So we want to acknowledge that we need to be person-centered and consider all of someone's life circumstances. And I think that's really important as a caregiver also, that to know that this is not a cookie cutter model, that we are not sensitive to individual needs. And so we train our staff to understand, and some of that's through a process or something that you may have heard of called motivational interviewing. And that, I love that concept because it enables us to really get into that person's shoes and to understand through their eyes how we can best support them. And then we use interdisciplinary teams, and I'll talk a little bit about that in the next slide. So yeah, if you want to advance, I'm watching my time. So we use interdisciplinary teams, and that's a team-based, person-centered approach for care management. And as I mentioned, that may occur within our plan. So for some primary care offices, we will provide care management, and that is managing medical, social, and behavioral health conditions, or we'll support those primary care practices. So just because primary care is providing the care management, it doesn't mean that we as a health plan aren't wrapping our systems around those practices to support transition. So if someone's leaving a hospital, that's the most difficult time. You're going from a setting where maybe you have a new condition and then you're going home. So there's an educational piece, maybe there's an equipment need. So we want to make sure during that really vulnerable time for folks that we're there to support them along with their family and other caregivers that are able to support them. So I think people haven't always reached out to insurance companies for support. And that's what we want to make sure that people do. Like pick up the phone, call us, ask about what support. Often insurance companies identify who has the needs and does the outreach, but you can absolutely ask your provider for support. You can call our customer service member support centers to ask for assistance too. Chronic care management is another area, multiple chronic conditions. It gets really confusing when you have multiple meds. And, having been a caregiver for a family member, and even as a physician, I'm a pediatrician, and it was my dad helping to care for him. And it was just almost overwhelming for me. So I know what this is like, from a family member perspective, that if it's hard for me as a physician, it's almost impossible. So often you need someone to help hold hands with you. A caregiver needs a caregiver, and we want to be that extra support for everyone. And then I do want to the last thing I'll call out on this slide is those high-risk social environment. So if you have social needs, even without a complex medical condition, we know that that's going to impact your health. right? And so, especially women of childbearing years, especially children, we want to protect their fragile brains and make sure that they have optimal outcomes long term. So, we are not just thinking short term and how do we manage people in the hospital like people might think of insurance companies, but we are trying to make sure that we have that very holistic approach and we create a healthier North Carolina long term. Next slide. So I did want to touch base because we had nursing home in the title. So nursing home care is covered. Medicaid will pay for nursing home care, however, only when it's medically necessary. And so we as the managed care organizations will work with the providers to help determine if members meet the nursing facility level of care requirements. And that again, there are typical criteria and standards, but it's always taking into context that individual perspective. And so that's something we work with the physicians on to determine whether or not you need the kind of services that are only offered in a skilled nursing facility. And then lastly, managed care while we are responsible for long-term services and support. So private duty nursing, personal care services, nursing, skilled nursing. For skilled nursing specifically, we are only covering for the first 90 days. So we will assess members during that first 30 days, and then we will notify the department if based on that assessment, we anticipate the stay will be past the 90th day, and then it goes to the first of the month. And so we will work with family members. We have a long history of working with skilled nursing facilities to ensure that if a member is there, that the transition to home, again, that transition support is really important. So we'll work with the members and with the facilities to ensure care is provided when they're in the facility, but also in that potential transition home. And I think I'm at my last slide. So I just want you all to know, and you can see these are recent slides of us in North Carolina. Like we live our culture. We have been here. We've been supporting the vaccine efforts for COVID. And I am going to say, you've got a spot, get your shot. So I do want to encourage everyone to get their COVID vaccine. I can't not do that as a physician. So thank you.
Thank you so much, Dr. Bucknor. That was awesome overview. Darcy, do we have any questions?
We do. Thank you, Dr. Bucknor. Dave shared with us some target dates for Medicaid transformation, and we know we are in a position we're still continuing to fight COVID-19. Will this pandemic impact Medicaid transformation in any way?
So this is where I get to use a Dave Richard quote, and I'm going to paraphrase him, but it's my favorite one. You know, in one of our sort of medical state meetings, he said, we are not launching into managed care despite COVID. We need to launch a managed care because of COVID. It has been really frustrating for me because I see what Medicaid and what our plans are able to do in other states to support the Medicaid population. And we haven't been able to bring this to North Carolina. So unless Dave has news for me today, we are a go for July 1st. And we have been excited for 2 years or more to start. So we are a go and we are ready. And I'm ready tomorrow. My systems may not agree with me, but we're really excited. And I think, in all seriousness, we have had just shifts because of the COVID and ways that we've been out in the community, as you can see, to get supports to people. And to miss that opportunity now is a little frustrating, but we can bring it in the future. So, yep, we're coming and we're excited and it'll be a really good thing.
Thank you. You mentioned that you're a caregiver for your dad. Two things related to that. We've had a question about, are these Medicaid services related to the caregiver's income? And then the second part of that would be, what advice in general would you give to caregivers about this transformation?
Yeah, and when I mentioned my dad, he actually passed away maybe 15 years ago. So I was much younger then, but and I was a physician at the time, but it was, like I said, it was difficult sort of navigating the system, and I learned a lot. And I feel like I get whenever I have to, whenever I'm on the other side, right, I treat it as a learning experience, and I feel like it's a way for me to make the system better because I get to see what it looks like. So I think for Medicaid transformation, the biggest um, advice I would give is you've got to educate yourself, and you've got to reach out and not be able to be afraid to pick up the phone and seek resources. I think for me, my concern now because of COVID is people are overwhelmed, like we all are. I'm at home working, like it's just tough. It's really, really tough. And to place sort of caregiver responsibilities on that, folks, I understand that that creates extra burden. But I think investing time into learning what you need to do and what it means and attending sessions like this is really important. I don't know if Dave wants to add anything to that.
Great answer. I think the one part about the caregiver, I think it's the individual that is the Medicaid beneficiary, and that doesn't
Oh, yeah.
right on the eligibility criteria. The caregiver, their income doesn't matter in terms of that support. So,
Thank you, Dave.
Thank you. And our last question is, what happens after the 90 days?
So I should have said that. I think it was on the slide. They transition back to fee for service. So even though Medicaid managed care is here, there are certain groups of people that won't be in managed care. And so that will be a group that goes back to fee for service. But people that have severe mental illness, children in foster care, IDD, there are population, the dual eligibles that will not be in managed care. And so once they hit that 90-day plus to the first of the month, they will go back to fee for service Medicaid. So we'll still have benefits. They just will not be enrolled with a managed care organization.
Great. Thank you. Thank you so much.
Thank you.
All right. Next, I'd like to introduce you all to Jonathan Williams. While he works on loading his slides, I will share his brief bio. Jonathan Williams is a graduate of Wake Forest University, earning bachelor's, master's, and law degrees there. He has since worked in private practice in the areas of elder law and estate planning. He was named a rising star in elder law by Super Lawyers in 2020 and in 2021. Thank you so much for joining us, Jonathan.
Thanks for having me. It's such a pleasure and a privilege to be with you all today. We've supported the Caregiver Summit for a few years and have been presenting here before, and it's just such a privilege to be with you guys who do so much hard work for the people that you love. And it's a privilege when we get to help families that are going through these journeys. So I'm going to talk about Medicaid in a little more sort of nuts and bolts fashion. I'm going to talk about the long-term care Medicaid benefit, and that is the Medicaid benefit that covers the nursing home services. And so this is one of those fee-for-service Medicaid programs that Dr. Bucknor was talking about. She actually gave a great lead into this, talking about how a Medicaid recipient might transition from the community-based Medicaid with the managed care organization into the long-term care Medicaid program, which would be in the nursing home. So just to be clear, there's lots of different Medicaid programs, and they're all a little bit different. The Medicaid program I'm going to spend most of my time talking about is called long-term care Medicaid, and that's the Medicaid that pays for the nursing home care. So as you see on this slide, there's a number of factors that are considered when it comes to applying and qualifying for long-term care Medicaid, and they're listed out there. The first one I can really kind of breeze over because Dr. Bucknor covered it, which is the medical need. So in order to get Medicaid for long-term care, you've got to have the medical need to be in the nursing home. That's got to be certified by your physician. on a form called the FL2 form. The second factor we'll talk about is income. Most of the Medicaid programs out there that you may be familiar with do have some income requirements, meaning that if your income is higher than a certain amount, you don't qualify for the Medicaid benefit. The long-term care Medicaid program is different. It does not have a strict income cap, but income is a factor. And I want to talk a little bit about how income works with the long-term care Medicaid program. Number three is the countable resources requirement. So in order to qualify for Medicaid, you've got to have countable resources below a certain amount. Then there's also the question of what assets are countable against that limit and what assets are exempt from that limit. And I'll talk about that a little bit as well. Number four there talks about community spouse rules. This refers to when a Medicaid recipient is married and they are applying for Medicaid. What about the healthy spouse who's going to stay living at home? That spouse is referred to as the community spouse rules. What rules apply to them? What are their income limits and things like that, asset and resource limits as well. And then lastly, the other factor would be the gift or transfer penalties. This is sort of commonly known as the 5-year look-back rule. And I want to give you the basics about the 5-year look-back rule as well. So if you're thinking about Medicaid eligibility for nursing home for your loved one that you're providing care for, we want to sort of go through the basics of that. So I'm going to jump right in here. So as I said before, the medical need was pretty much covered already. If you have a medical need for skilled or intermediate care in a nursing home, your doctor can certify that on an FL2 form that's submitted to the state, and that will document the medical needs such that you can get the long-term care Medicaid benefit. Next is income. So like I said before, there's not a strict income cap on long-term care Medicaid, but income does matter. The way that the Medicaid benefit works for nursing home care is that the Medicaid recipient has a certain financial obligation that they have to meet each month. That's called their patient monthly liability, and that is calculated based on their income. So for example, if you've got $1,500 in income each month from Social Security or pension or whatever, then your patient monthly liability is going to be that amount minus a couple of deductions, including any health insurance premiums like your Medicare premiums, your Medicare supplement premiums, your Medicare Advantage premiums, and you also get to deduct a $30 monthly allowance for personal needs. But the remainder of your income will then be paid over to the nursing home as your monthly liability. And so if that's $1,200 or $1,300 or whatever it happens to be, that's what you pay each month. And then Medicaid will pay the remainder of the charges for the services. And so the lower your income is, the more Medicaid pays out, the more benefit you get, but there's not a strict income cap. But having said that, of course, there are going to be folks who do have a high enough income who can pay for their nursing home services out of their income without having to dip into their bank account or their savings. And if that's the case, then the Medicaid benefit is going to be exceedingly limited. And so, there does come a point above which a certain level of income just isn't going to apply for Medicaid, even though there's no strict income cap. So that's kind of how income works with the long-term care Medicaid. Next, I want to talk about the resources. The resource limit for a Medicaid recipient in the nursing home is $2,000. So if your countable resources are above $2,000, then you won't qualify. So the question is, well, what's countable and what's non-countable? I'll start with the non-countable. This is not an exhaustive list, but this is a list of the main non-countable resources that you get to own and still qualify for Medicaid. As you see there, first is a primary personal residence, whether that's a house, a mobile home, even a motor home. If it's your primary residence, then it's going to be exempt unless it's over a certain value, which is around $600,000. So if your home equity is lower than that, then your residence is going to be exempt. There are some other real estate interests that can be exempt. I don't want to go into the details of that because it would kind of get beyond the scope of what we're doing today. But there are some other real estate interests that can be exempt. But in general, if you own a vacation home or if you own other land in your own name, that's generally going to be countable as an asset. Another non-countable resource is your vehicle. So you get to own a vehicle and still get Medicaid. That doesn't count against your limit. And that's true even if you're not able to drive. You're still allowed to own a vehicle so that somebody else can provide transportation for you in your vehicle. So that's allowed. Number 4 there is most of your personal items at home, most of your other tangible property. So your furniture, your clothing, your jewelry, things that you own in your home are generally going to be non-countable. Next is life insurance. There is a limit of up to $10,000 in face value life insurance you're allowed to own without it counting against your resource limit. But also there's other types of life insurance like term life insurance that don't count against that limit because they don't have a cash surrender value. So you are allowed to own some life insurance and still qualify. The next one there is Medicaid compliant annuities and promissory notes. I mentioned this mainly to introduce you to the idea that there are some financial products that you can have that are designed to be owned and not count against the Medicaid resource limits. So if you purchase a certain kind of annuity that's geared toward Medicaid eligibility, you can own that annuity, receive payments from that annuity. Your ownership interest is exempt. But the income you receive from the annuity is countable as income, which would be potentially added to your monthly liability to the nursing home. But I introduced this just as a planning tool. These are things that sometimes we help our clients obtain so that they can get the benefits that they need. That's an option that's out there. And then lastly is prepaid funeral and cremation services. You can, of course, purchase a pre-need funeral contract or cremation contract. If that contract is irrevocable, then your interest in that contract is also not countable. The Medicaid program, of course, wants you to prepay for those services if you can. So this is a list of major non-countable resources. Let's look at the countable resources, basically everything else. So your retirement accounts, your savings accounts, your brokerage accounts, whatever other kind of financial resources you may have are generally going to be countable. Like I said, your resource limit, if you're the applicant, is $2,000, which doesn't leave a lot of room, which is why I put the exclamation point there. But then we have the question about, well, what about the community spouse? What about the healthy spouse who's living at home? Do they also have a resource limit? And the answer basically, the idea behind the 5-year look back rule is to prevent folks from simply just giving all their stuff away to their kids or to their loved ones, and then turning around and saying, "Well, I'm financially qualified. I want the Medicaid benefits." The government wants you to spend your resources on your care, and then Medicaid will be there when you don't have any more, and you're not able to provide for those needs anymore. And so they do penalize you if you make gifts to qualify for Medicaid. And they look back up to 5 years, which is why it's called the 5-year look back rule. So when you apply, Medicaid can ask for financial records, and they ask you to report any gifts that you've made in the 5 years prior to application. And then they'll tally up the value of all these gifts that you've made, and they'll divide it by $6,810. and that's how many months you have in a penalty period. And the way the penalty period works is even though you're eligible for Medicaid, you don't get the benefit because of the gifts that you've made. So generally making gifts less than 5 years before you apply is generally not a good idea, because you're going to have this penalty period where you don't have the funds, but you don't get the benefit because of the gift penalty. Now, there are some exceptions to this. Spouses are able to transfer assets between the two of them. So, if a married couple has a bank account and a savings account, maybe they have 10 or 15 or $20,000 in the bank, they can simply transfer all of those funds into the community spouse's name, the healthy spouse's name, and that gets the Medicaid applicant below $2,000. The healthy spouse is also below his or her resource limit. So you can transfer assets between spouses. That's perfectly fine. If you have a child who has been adjudicated disabled by Social Security or some other government entity, you're allowed to transfer assets to them without penalty. And then there are other transfers that you can make if you can show that you made these transfers for some other reason. And so basically the way the law works is that the Medicaid program is going to assume that any gifts that have been made, that is any transfers of assets that were made without fair compensation, were made for the purpose of getting you eligible for Medicaid. And so if you want to show otherwise, the burden is on you as the applicant to show otherwise. And so, if 3 years ago your child had to file for bankruptcy and wasn't able to pay their bills, and you gave them some money to help them pay their bills for a couple of months while they got back on their feet or whatever, that's probably not going to be penalized because you can show that it was done for some reason other than helping you qualify for Medicaid. But it's on you. You've got the burden to show that. So you would have to provide whatever evidence you need to provide to the caseworker to show that that was a gift made for some other purpose. Similarly, if you've been giving gifts to your grandchildren every year for their college education, you put it in a 529 account, and you've been doing it for 8 years or 12 years or whatever, there's going to be pretty good evidence that this is the kind of thing you've done for family reasons and not for government benefit reasons. And so you may be able to demonstrate that you shouldn't be penalized for that. But if you do have the penalty, you can also apply for a hardship waiver. And what this is a way to prevent folks from really not being able to pay for their care at all. So the idea would be that if you've got the gift penalty sanction, well, you've given your assets to other family members who are then going to be able to chip in and cover your care while you wait out the penalty period. But if you can demonstrate to your caseworker that money is not available anymore, that you've done everything you can to try to get it back from your child or whomever you might have given it to, or if they've lost it because they got sued for back taxes or something, if you can show that the funds aren't there anymore and there's really no other way for you to get the care at all, and you're going to be left without any care at all, without the Medicaid benefit, then you can apply for a hardship waiver and potentially get the gift penalty waived. And then, like that implies, what that means is if gifts have been made and you're being penalized for them, one way to get rid of the gift penalty also would be for the child to just give the money back. And so you can cure a gift and eliminate the gift penalty that way. So we could talk for an hour and a half about the ins and outs of the 5-year look back rule, but that's the basics. So I'll move on there, and then we'll see if we have questions about that. Another factor, which I didn't mention on the first slide, but it is something that anybody that applies for Medicaid needs to know about, is the estate recovery program. What that is if a Medicaid recipient dies, then Medicaid has the right to assert a claim against that person's estate. So if your loved one was in a nursing home for 8 months and Medicaid paid out maybe $80,000 in benefits, then upon the death of that recipient, then when you file their probate estate, you've got to notify Medicaid, and Medicaid may assert, and probably will assert, a claim of $80,000 saying, we're a creditor who has a right to get paid from this estate. And so the estate recovery program is out there, and folks need to know about that. But as you see at the bottom there, if there's a surviving spouse, then Medicaid will defer that claim so that the surviving spouse can continue to live and meet their needs with the resources that are left for the surviving spouse. A couple of planning tips, and in the interest of time, I'm mostly going to skip over this, but my general message here is that you never want to wait too late to plan for Medicaid eligibility. If you're thinking that you or your loved one might need to apply for Medicaid to cover the costs of long-term care, the sooner you start thinking about that, the better. The better you'll be able to take advantage of what the law allows you to protect and get eligible as quickly as possible. So we encourage folks not to wait too late. But on the other hand, we also want to encourage folks not to ever think it's too late to plan. If your loved one just had a major health event yesterday and you're going to need to apply for Medicaid sometime soon, there's almost always things that can be done. For example, if they own a home and they've got a mortgage on the home and they've got some cash in the bank, well, if you pay down that mortgage, you're reducing your countable resources because you don't have that cash in the bank anymore, and the equity in the home that you get in return is part of your home. It's exempt under Medicaid rules, and so essentially you're converting your cash, which is countable, into home equity, which is not countable. And so there are things like that almost always can be done to hasten Medicaid eligibility and allow you to protect what the law allows you to protect. And you would want to get some good advice about that if you can, if you have the opportunity to do so. There are a couple of other programs that I do want to mention before my ending here. One is PACE Medicaid. This is a different Medicaid program from the long-term care benefit, but it is similar. PACE Medicaid is a managed care Medicaid, and it's meant to allow folks who otherwise would need to be in a nursing home to live instead at home with the benefits that the PACE provider gives. And so if you go on to PACE Medicaid, then you're enrolled with this managed care organization. They're very localized, so it's county by county. Usually, one or two counties is their geographical area. The needs, all of the medical needs of that PACE participant. So they provide primary care, they provide physical therapy, occupational therapy, they provide hospital coverage, they pay for medication, dental, vision, medical equipment, they pay for transportation to and from the PACE center and to and from medical appointments and things like that. And it's built around this daycare model. So, if you're in PACE as a participant, you might go to the local PACE center a day a week or 2 days a week, or sometimes every day to get the services that you need. But you're living at home and you're spending your nights at home, and so this is a way that folks can get their care needs met without having to live in a nursing home. And so this is a great program that we've helped folks get eligible for in the past, and I recommend it for folks that really want to live at home. It's not going to be for everyone because not everyone can continue to live at home even with the PACE support. Some people just are going to have their needs met at a skilled facility. But for the families for whom this is a good fit, it's a great program. A couple of others I just want to touch on real briefly. There is a benefit program for assisted living. It's called State County Special Assistance. It's similar to Medicaid. The eligibility rules are similar, but when Medicaid overhauled their rules about, maybe 12 or 13 years ago now, the special assistance rules didn't change along with it. So special assistance kind of worked like Medicaid did, in 2002 or something. But it is out there, and a lot of the assisted living facilities will talk about getting eligible for Medicaid. What they generally mean is special assistance, but people that are on special assistance are also eligible for Medicaid, so they may get Medicaid personal care services and other services through Medicaid. And then lastly, like I said before, long-term care Medicaid and PACE Medicaid are only a couple of a large number of Medicaid programs that are out there. There are plenty of what you might call community Medicaid programs that seniors can take advantage of, like Medicaid to age blind and disabled individuals, which is going to be that managed care program that we've been talking about a lot of today. There's the personal care services program, which I mentioned when I talked about special assistance. Most of those other Medicaid programs, however, do have income caps, and special assistance also has an income cap. So it's a little bit different than a long-term care Medicaid, but there are many programs out there. I think that's it for me, but I've seen some Q&A come in, so we'll see what questions we have, and I'll also defer to my illustrious co-panelists to correct me if I got anything wrong, because I'm the low man in the totem pole here. I'm very humbled to be on with these great folks.
Thank you so much, Jonathan, for this great overview. Darcy, I know we have a few questions and we're running out of time, but I want to make sure we get to them because there are some great questions in the Q&A.
Mm-hmm. Thank you. Thank you, Jonathan. Question about Medicare and Medicaid. If I'm covered by Medicare and I need to be in a nursing home, do I ever transition to Medicaid?
You can be on both. So most people that are in a nursing home on Medicaid are also in Medicare, either Part A, Part B, or they're using a Medicare Advantage. So most people are going to be on both.
Thank you. Can a life insurance policy be cashed in to prepay for funeral expenses within the 5-year look back?
Yes. That's not a gift. That's a transfer for value. And the asset you get back, namely the funeral services, is an exempt asset. So that's a great use of funds.
Thank you. Can someone apply for Medicaid if they have inheritance property?
If they have inherited property, like heirs property, generally yes, because if you've got real estate that's co-owned with other heirs, it's probably going to be an exempt asset. But that's one of the lists of real estate assets that's generally exempt. I would caution you that anything I say is going to be really depending on a case-by-case basis. So I would encourage somebody to have that looked at by either an elder law attorney or somebody else who's qualified. But generally, probably.
Okay,
yes.
Thank you for being so thorough with us today.
Oh, sure.
Right. Once again, we want to thank our guests today for this excellent review of Medicaid and Medicaid managed care. This session was recorded and will be posted to the website later today. A reminder that our next and final webinar will be next Thursday, April 29th, also at 2 p.m., where we'll cover traditional Medicare versus Medicare Advantage plans. I encourage you to join us then. Your registration and the Zoom link you received for today's webinar are good for all 4 weeks, so you can use that same link again next week. If you have any questions, please email us at summit@transitionslifecare.org. Once again, that's summit@transitionslifecare.org. See you next week.